The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Okay, good day, dear listeners. We are starting immediately. Thank you for your patience. We appreciate it immensely. This is Limi Hospital, Limi Children's Hospital, one of the three main branches of the Limi Hospital Group. Like you can see on our slide, we have three different specialty hospitals, and today's webinar will be anchored by the Limi Children's Hospital. So who are we?
So the Limi Children's Hospital is a designated specialty hospital for pediatrics, neonatology, and adolescent medicine.
All right, thank you. So, yeah, so we have a goal that drives us, and we have this belief that the family will be healthy if the child is healthy, and that way they will be happy. So we have a vision: happy families through great healthcare. Yes. A happy child is happy. A healthy child is a happy child, and a happy child makes a healthy home. Right. So today we have the presentation in front of us. Chest pain in children, cardiac versus non-cardiac. I am Dr. Igoche Peter, and with me today is
Dr. Faiza Aliyu.
All right, thank you. Yeah.
So at the end of this presentation, we expect that our listeners should be able to differentiate between the cardiac and the non-cardiac causes of chest pain. We should also be able to highlight all the diagnostic approaches to any child that presents to us with chest pain, and also to identify what we call red flags, cardiac red flags in children with chest pain.
Yeah, so it's important because chest pain could be cardiac or non-cardiac, and what are those danger signs? It is important so we do not get to worry too much, and we do not get to reassure baselessly. Yes. Okay. So we know that chest pain, because it's often sinister in adulthood, that anxiety is transmitted to children with chest pain. Maybe not so much about the children, but their parents. And maybe for adolescents, they're also really, really worried about it. We know that there is no gender predilection. It can occur in boys, just like it can occur in girls. And chest pain is a complaint. And like every complaint in medicine, we have to take a very good history. So the history taken in pain remains constant, and then the variations now differ based on the etiology of the chest pain. Yeah. Thank you. It's important that those ones that are deemed cardiac, will require the review of a pediatric cardiologist. Okay.
So it's important to note that the most common form of cause of chest pain is not actually cardiac.
Yes, that looks ironical because the anxiety, so the number of cases of chest pain I've seen in clinic, oh my God, it's a lot of referrals from different places. And this is because the parents are really anxious. But now we are looking from the statistics, frequency of those that present in emergency room, and even those that come for OPD, that cardiac conditions are actually the least frequent of all of them. Yeah.
Yes. So from the table, we can see actually the most common is idiopathic, followed by musculoskeletal, then respiratory, then gastrointestinal, psychogenic, and then cardiac is the least cause. So referrals usually in cardiology clinics are when after careful history and examination, and you find out that it's not actually a cardiac cause.
Yeah, so most of them end up not being cardiac, but really, really important. So we want to look at the system-related causes, because if it's not just cardiac, then what are the other systems? And if it's cardiac, but cardiac is not the most common, what are the other systems? Because a patient is not going to be satisfied that, oh, it's not cardiac. Yeah, the level of anxiety drops. Not as okay, but what is it and what are we supposed to do about it? Yes.
So starting from the musculoskeletal system, one of the most common causes in children especially is costochondritis.
Yeah.
And that usually occurs after a child has had any history of upper respiratory tract infection, any trauma to the chest. So what you realize is the child will present with a history of a sharp chest pain that is anterior, and it can be left-sided or right-sided, and it can be both. So that helps us to differentiate, because when we are talking about cardiac, cardiac is precordial, on the left side.
So except it's dextrocardia. Except the child has dextrocardia, right? Yes. Okay, fine. But commonly the precordium is towards the left side. And costochondritis can be bilateral, or either of the sides.
Yes. Then Tetza syndrome is a rare form of costochondritis in which it's not just inflammatory changes at the costochondrial junction. The child will also present with a fusiform shaped swelling, which is non-suppurative, right? Yeah. And usually find it at the third and second costochondrial junction. So that helps us to also diagnose, okay, is this just costochondritis or it's also a Tetza syndrome?
Yeah, so this syndrome, we recently, 3 weeks ago, had an adolescent about who had this, and the mother, being a very literate person, was really, really worried. Now, he met all the criteria. The child has had soft tissue X-ray, soft tissue ultrasound, has had X-ray, and at the point we met, because of maternal anxiety, the next thing for them was do an MRI. But everything met up with the diagnostic criteria, what it looks like, the Texas syndrome. So it's important. Now, musculoskeletal pain, there is something we need to state very clearly. It is easy to localize. So it's really, really straightforward to localize. It's not diffuse. So usually in clinic, we try to distract them. Okay, let me see your index finger. All right, from your right hand. Okay, close your eyes. Now, can you please touch where the pain is? They actually get where that pain is. That's one. Okay, now open your eyes. Let me see your left index finger, touch it. Now, if the pain location is not specific, you see them moving their hands from one side to the other, and it's not going to, but now, musculoskeletal pain usually is localized. It can be, yes, palpating it will trigger the tenderness there. And movement, when the child moves, inspiration, expiration, it's also possible to
during any strenuous activity or exercise. Now, sleeping rib syndrome, it's a rare syndrome in which, because between the 8th and the 10th ribs, their insertion into the sternum is not really well adjusted because the ligaments there are weak. So it's easy for those ribs to slip, and that can cause chest pain for the child. So that is also actually very easy to localize for the child, and upon palpation there will be tenderness, and it can be more severe upon breathing, inspiration, or coughing.
Yeah. So the next one is trauma. So a very funny incident of a very active young boy, about 8 years old, from very strict parents who will not want to hear that their child fought in school. So all the child told them was, oh, chest pain. I had chest pain on the left side. And so this mother was really, really worried. And in clinic, taking history, I had to ask, come on, I hope there was no fight yesterday in school. And he said, some mentioned the name. They were fighting and the young man hit his chest on that side. So the mother was embarrassed that the child was fighting in school. But yes, the boy gave out the history, trauma to the chest. Yeah, during fights, from sports, accidents, it's possible. Now, overuse of chest wall from strain, from coughing, and any of the other abnormalities of the rib cage can cause it. So musculoskeletal pains, the commonest identifiable because we have idiopathic. Yeah. So it could also be respiratory. Okay. So in respiratory, we know that it could be the commonest ones are asthma, pleurisy, or pneumothorax, right? In asthma, there is a combination of the symptoms of wheezing, breathlessness, cough, and chest tightness. Now that chest tightness can be reported as a pain, but the pain in asthma in that case is constricting.
Yes.
So chest pain, in this case, unlike musculoskeletal that is localizable to a position, the chest pain in respiratory for asthma is diffuse. It's that tight feeling. Yeah.
Yes. So in pleurisy, the nature of the pain is usually prescribed as a sharp pain, which is localized as well. And the pain is worse when the patient is either coughing or when they take a deep breath. So any child with a history of such a pain, we actually think of a respiratory cause, most commonly a pleurisy.
Yeah.
In pneumothorax, the pain is at the same side where the lung is affected, right?
Yeah.
And it can also refer to the same shoulder.
Yeah.
Where you feel the pain. So it can refer to the same shoulder of the same side where the lung is affected. Then it is often felt in the upper anterior part of the chest.
Yeah. Okay, fine. So history is really, really important. In pleurisy, inflammation of the pleural space, the pneumothorax, especially if it's tension pneumothorax, that one will even present as an emergency and will need urgent attention. Yeah, so psychogenic stressors, this was very fun in clinic. I can literally say we found almost each of the classifications in clinic. So we had this child of a chief justice, a very, very senior, some person in the legal profession, and he travels a lot. And the boy started complaining about 9 years old, complaining of chest pain, and they've gone round. So they had to refer for cardiology review. And on asking, how bad is this chest pain? No, he complains of sometimes it would just come and go. And while they were talking about it, the boy said the chest pain has come. He said the chest pain has come. Okay, please touch it. And he was just rolling his hands around the chest. Okay. Now the next thing was, I felt something was amiss because he was clinging to the dad so much. Okay, fine. Ma, can you let this boy just go outside and watch cartoon so that we speak as parents, adults to adults? Because I felt something was amiss here that we needed to talk about. And the mom insisted we should stop talking about it when she comes back. She'll take the child to the play area where cartoon will be on, and then come back. And the point was that the father travels really a lot, like men hustle to take care of family, right? So, but then there is this aspect of parental deprivation that follows the same hustling. And the history came out that there was time the father went to US. As soon as he was landing, a few days, the boy, chest pain. On citing the father's arrival, the father had to break the trip. He stopped. Now, what was that? Now, by the time we added everything, the mother was like, oh, we need you around. So there was, the wife also had the need to see the husband, but she could suppress it as an adult, but the child could not. So parental deprivation, and it could manifest. And the boy realized that when he complains of chest pain, he gets the attention of the parent. Yeah, the father in particular. So it was good for him to always say chest pain. Ordinarily, without chest pain, he will move around with the dad. But now chest pain, so they have been visiting different hospitals, and it's like fun for him to go around. So stressors, parental deprivation, all about stressors coming, death in family, marital discord, and all that. And then some other psychologically related concerns like conversion syndromes, somatization, that's bringing is the manifestation of intrapsychic conflict, physically manifesting outside. And especially if it's found that it gains an attention when it is chest pain, because parents understand as adults, you don't play with chest pain. And so if the child is now complaining of chest pain, then it's worth attention. Yeah.
All right, so gastrointestinal. Some of the most common causes of gastrointestinal are gastroesophageal reflux, peptic ulcer, gastritis, mosquitochondritis. Now, in gastrointestinal, the chest pain is usually retrosternal and is described as a burning pain, right? And it can be made worse either by the changing position of the child, or when the child eats certain foods or does not eat, right? So there can be some associated symptoms like the water brush, which is the child will have excessive salivation in order, as the body is trying to neutralize the excess acid that is produced. There can also be associated dysphagia and heartburn. Now, this can be caused either by the gastroesophageal reflux disease or peptic ulcer, which we see a lot in clinic, especially children with H. pylori, which is very common. Then it can also be gastritis or esophagitis. And
the gastritis can be NSAID induced. Now, the problem with gastritis, so they had pain for something else and misused analgesics, NSAID, and now had gastritis, and they see it as pain, so they take NSAIDs more in order to treat the pain and exacerbate the NSAID-induced gastritis. So history of drug intake, analgesic abuse matters a lot in this case. And then we see the nature of the pain, burning in nature or sharp pain, very, very important to hear. Yeah. Okay, so we said miscellaneous. It's another class of the causes, so which does not fall particularly under a given class. Yeah.
So like the precordial catch now, that is the exact cause of this pain is not really known, but you see that the person will present to you like holding the one side of the chest, like it's one-sided, and it's sharp, right? And it's the person bending and slouching, trying to relieve the pain. But the pain is actually relieved when they stand upright and they take some deep breaths, right? So that causes the relief of the pain. And we also see this chest pain in some sickle cell disease.
Okay, so also for precordial catch syndrome, so we've actually made a lot of these diagnoses. So commonly in children, younger age, like from that 5 to 13 years averagely, but it can occur even before or after that. So the pain is sharp. So you ask them, how can you describe this pain? How do you feel? And they say they have the feelings of pins and needles. Now it comes transiently. It can last for like a few seconds to not more than 3 minutes. Yeah. So sometimes it's really, really intense. For a few, the cause is not known, but a few of them may have psychological association. Yeah. So this kind of pain, when it occurs on the left side, it's worth cardiac evaluation because it almost looks like it is related to cardiac pain. But by the time we do ECG and echo, we realize that really there is nothing. And a careful history will show. Sometimes there's this feeling of lightheadedness they have and have to breathe in shallow breaths just to get themselves. Yes.
It's also important. It can also be chronic actually. So that's when the psychogenic cause can come in because they can keep having it for months.
Yes, yes.
And you investigate and there's nothing causing it. So in sickle cell disease, vaso-occlusive crisis, we're talking about the acute chest syndrome in sickle cell because the occlusion of the vessels will cause chest pain that can be also similar to cardiac actually.
Yeah. So sickle cell causing chest pain can come through multiple mechanisms because even under cardiac, sickle cell can still show up. So sickle cell, the vaso-occlusion of the vessels supplying the rib cage can cause the vaso-occlusive crisis. But coronary artery affectation can affect the heart muscles itself. So for this, we're talking about affecting the musculoskeletal system by vasocclusion. Yeah.
So we also mastalgia, especially in females, right? There is this fibroadenoma that we have, and that one usually causes this pain. And some women have cyclical breast pain. So some can misconstrue it with chest pain, and it can be a cause of worry for the girl. Then herpes zoster as well, because of the dermatomes that are supplied. So affectation of that by the virus can be fused with chest pain.
Yeah, it's okay, fine. So let's go to cardiac, the most feared, that good enough is a rarest. Yeah. So just like we said that musculoskeletal pain can be localized, some respiratory pain diffuse, and then the gastrointestinal pain burning in nature, retrosternal. Now, chest pain that is of cardiac origin is usually precordial and radiates to the left arm or the jaw region. It's important that the precordium is the center of the pain. But please don't forget that these children could, in rare occasions, have dextrocardia. So a cardiac examination must include all the steps: inspiration, palpation, at least auscultation. Yeah, fine. So it's described as crushing pain or it's heavy. For cardiac, because of the innervation, at times there could be some autonomic symptoms that could be associated. Now, sweatiness, nausea, pallor, which it's just there, but actually it's not as though the PCV is there. Yeah. By the time we now start talking of exacerbation with exertion, we are really getting really serious. Yes, yes. Then it could be associated with fainting episodes, syncope, or palpitations, depending on the age of the child.
Or pre-syncope, which is lighted, you feel like dizziness before you actually fall down. So it can be any of this.
Yes. It's okay, fine. So what are the cardiac causes?
So we classify the cardiac causes into the ischemic ventricular dysfunction, inflammatory causes, and arrhythmias. Now, in the ischemic ventricular dysfunction, there are these ones that are structural cardiac causes, like the aortic stenosis. Now, that one actually causes a triad of symptoms, right? It causes exertional angina, which is the chest pain, the cardiac chest pain, exertional syncope, and exertional dyspnea. This is because there is an obstruction, right? So the heart is trying to pump the left ventricle. There is increased work by the left ventricle to pump blood against that obstruction. That causes increased myocardial oxygen demand, right? That can also cause angina for the patient. Pulmonary stenosis.
So there's insufficient perfusion.
Insufficient perfusion. Pulmonary stenosis as well. So the obstruction is still there. The pulmonary valve is not open during it. So there's still that increased work of the heart to pump blood against all that. So
increased
tachycardia, with tachycardia and everything. So that causes the classical angina pain you see in this patient. With hypertrophic obstructive cardiomyopathy, it's important to note that this is because it also causes obstruction, right? But it causes obstruction of the outflow tract of the left ventricle.
Just like the aortic stenosis.
Yes, but this occurs during systole, right? Mid-systole, because during systole, the mitral valve leaflets are closed, are moved to block the outflow tract. So that blockage now causes that pain, and it can cause increased myocardial oxygen demand, tachycardia, and then the patient will experience cardiac pain. Mitral valve prolapse, the exact correlation for that is actually unknown, but it might be due to the dysfunction of the papillary muscles involving the mitral valve. So that causes, is important to note, in mitral valve prolapse, the pain is not actually associated with exertion. It can just come sharp. So that causes some sorts of confusion, like is it cardiac, is it non-cardiac? Right?
So this kind of cases, well, the next slide will discuss the clinical findings and the basic investigation findings, even before we do echocardiography. Just to be sure, dear listeners, we want to be sure that we are audible enough, and please understand that questions as we present can be put in the Q&A box so that we respond as we make progress. Yeah, just an emphasis, the hypertrophic obstructive cardiomyopathy, because in systole, there is a contraction, right? And so the mitral valve, which is the inlet valve, is closed. whereas the outlet valve is aortic is forced open. Yeah, so there's that. Yeah. Okay, fine. So coronary artery abnormalities. I've already talked about sickle cell, saying that we discussed sickle cell under miscellaneous, knowing that the vaso-occlusion can cause ischemic pain on the ribs, which is musculoskeletal. Now, coronary artery abnormalities are also known, so that's why it's classified under coronary artery here. Now, anomalous left coronary artery from the pulmonary artery is notorious for an ischemic-like pain, because we know that the coronary arteries arise from, so we see the left one from around the 4 o'clock position, the right one from around the 9 o'clock position. Now, the left coronary artery, these are arising from the aortic root, but now arising from the pulmonary. Yeah, so the heart is supposed to be supplied by oxygenated blood, but it's now arising from the pulmonary. So the branches of that left coronary artery is carrying deoxygenated blood, so it's now perfusing the where it should normally perfuse, and there are some ischemic-like changes. Yes. Okay. So aortic dissection and aneurysm, especially when there are children who have connective tissue disorders. So when we see people with Marfan syndrome, Turner syndrome, yeah, so we bear all that in mind also.
All right, so in arrhythmias like supraventricular tachycardia and ventricular tachycardia, we usually see this in patients that already have a long-standing family history of arrhythmias, right? So either of the Brugada syndromes or Wolff-Parkinson syndrome, right? So what happens is, like in, for example, Wolff-Parkinson, right, it causes the re-entrant type of supraventricular tachycardia because there is an extra connective tissue, right? So that causes the excitation waves to bypass the AV node and to go into the ventricle. So that is why we call it re-entrant supraventricular tachycardia. So even on ECG, what you will see is because of that, the PR interval is shorter because the AV node has been bypassed
by an aberrant
pathway, and the QRS is wider with a delta wave. Now, in Brugada syndrome, it also causes supraventricular tachycardia because there is the affectation of the sodium-calcium channels of the heart, especially the gene that is responsible for the sodium channel, the SCN5A gene, right? So it encodes for the sodium channel reuptake. So when there is an effect in that, it causes supraventricular tachycardia. Like also long QT syndrome, where the QT interval is prolonged more than 46 seconds. So children like that can present with arrhythmia, and because of this palpitation and tachycardia, they will now describe it as chest pain. And the increased tachycardia and palpitation will actually increase the myocardial oxygen demand. So that also causes that type of anginal pain for them.
Yeah, so a lot for arrhythmias and the ischemic ventricular dysfunction. Now, for inflammatory conditions, we have pericarditis when the pericardial space is inflamed. So the visceral pericardium, the parietal pericardium. Yeah, so we have a question. Please, we have a participant raising up the hand. Will you kindly okay, thank you. So thanks, we'll increase our volume. Thank you. All right, fine. We've discussed the ischemic ventricular changes and arrhythmias. Now to the inflammatory cardiac causes. We talked about the pericarditis, which could be rheumatic. It could actually be bacterial or viral. The most important thing is there is an inflammation of the pericardium, viscera most likely, or even the parietal pericardium. There could be some effusion, and the effusion can become really, really infected. So we've had reported cases of bacterial pericardial effusion pericarditis. And the pericarditis can be constrictive in nature, now impeding diastolic filling. Yeah, so really, really painful. So a myocarditis, usually viral, affecting the heart muscles. So the heart muscles themselves are affected. So there is really, really pain. And then Kawasaki disease, which is although not very common in the environment. Yeah. It's okay. Fine. So okay, so we've talked about the cardiac. So let's expatiate more on the cardiac causes of chest pain, what we find on examination, what we find on ECG, what we find on chest X-ray. A lot has been spoken about severe aortic stenosis. Now, the aorta, if we are trying to auscultate the 4 auscultatory areas, the aorta, we are looking at the upper right sternal edge, right? So there will usually be a grade 3 or higher systolic ejection murmur, not pansystolic murmur, because the aortic valve is severely stenosed. Now, at ejection, the blood tries to force and a lot of turbulence through that place. So it's occurring due to at the ejection phase of the cardiac cycle. So a systolic ejection murmur at the upper right sternal border that radiates to the neck. This is found in severe aortic stenosis. Now, because it is an afterload problem of the left ventricle, there will be left ventricular hypertrophy. And this could be with strain or without strain. Now, from chest X-ray, so even if one cannot explain the ECG, which should be easy, left ventricular hypertrophy is straightforward. However, but chest X-ray can show that there's prominent ascending aorta or the aortic node. So it's prominent there. The area where aorta should normally be is prominent. For severe pulmonary stenosis, it's more like the opposite side, because the pulmonary area for auscultation is the upper left sternal edge, right? So again, it's an obstruction that is occurring at the ejection phase. Yeah, so a systolic. So it's a systolic ejection murmur that is loudest at the upper left sternal edge. So ECG will also show a right ventricular hypertrophy with strain. Yeah, so the pulmonary area is prominent from chest X-ray. Yes.
In hypertrophic obstructive cardiomyopathy, on auscultation, you can find variable heart murmurs. This is because it's also an obstruction. That
so it's a spectrum, depending on the extent.
It can cause different types of murmurs,
yeah.
Right? So, and because it's a strain, like we said, trying to pump against the left ventricular outflow. So there will also be left ventricular hypertrophy.
Yeah, so it's more like a functional obstruction, sort of, depending on the hypertrophy of the interventricular septum and the left ventricular wall. So classically, there's left ventricular hypertrophy.
So you can see that the heart will either be mildly enlarged, mild cardiomegaly, then there is a globular shaped heart, which is diagnostic.
By that time, it's getting really bad.
Yes.
Yeah.
Now, in anomalous origin of the left coronary artery, so you either hear a soft heart murmur or no murmur at all. Now, the ECG will show anterolateral myocardial infarction. This is because, as we talked about, the left coronary artery arising from the outer is supplying the anterolateral aspect of the heart, of the left ventricle. So it's being perfused by the oxygenated blood because anterolateral ischemia. So chest X-ray will show moderate to marked cardiomegaly. In pericarditis and myocarditis, once you place your stethoscope on the chest, you hear a friction rub.
Yeah. So it takes skill to hear this. For an older child, it may be better to say, hold your breath for some time, so we don't have an interference between the respiratory sound and the heart sound itself. But there is a pericardial friction rub that is heard, and the heart sound being muffled means it's getting distant, and being distant means there's fluid in the space. Yeah, so if it's just pericarditis, the pericardial friction rub is, but if we have effusion present, means the pericardial space is now widened. Yeah, so with fluid, it's now widened. So the space for conduction of the sound of the heart sounds become more. So there's muffling of the heart sounds, which someone can say is distant or sounding far away. Yeah. So on ECG, we find that the voltages, the low QRS complexes are low. Why? Because we have it's obstructing. The leads are not picking it. It's far away from where the leads are picking. Yeah. So the ST segments are shifted. There could be arrhythmias, but classically is the low QRS complex and either ST segment depression. Yeah, fine. So there's cardiomegaly of varying degree, because if the pericarditis is primarily constrictive, it may not be really significant, but if it's not, where you have a lot of fluid in the space, so the space is enlarged because of the pericardial effusion, we're giving it the shape of a water bottle heart, which is the older terminology that is used. Yeah. Okay, so now we've talked about all the systems that could be affected. Talked about cardiac, musculoskeletal, respiratory, gastrointestinal, miscellaneous, right? And psychogenic. Yeah, so let's look at the diagnostic management algorithm for chest pain. This is important that we run through all this for children when we have chest pain. The algorithm is going to depend largely on the history that has been taken, right? And the examination findings. So let's move on. So you look at this table, assuming we have the child is presenting to us. Now, we take a detailed history. From history, we can suspect musculoskeletal, right? And then we examine. And we examine the third left intercostal space at the costochondrial junction, and we feel some bulging that is painful. We are thinking of the Tiggs's syndrome already, right? So we rule out history of trauma. Now, an ECG is important depending on the case. So we rule out the history of trauma and intense physical activity. We know that musculoskeletal pain is usually well localized and it is reproducible on palpation. So we palpate and see. Now, when there is movement, it's worsening. So these children want to stay calm. They do not want disturbance. Usually it's musculoskeletal. Musculoskeletal will require rest and the need for probably NSAIDs, giving cautiously, right? So if it's not, if the history does not follow one of these, the ones for musculoskeletal, we check. Is sharp pain over multiple costochondrial junctions, and is there pain on palpation, but there is no swelling? Because if there's swelling, we think of Tiggs's, but if there's no swelling, think of the costochondritis. They will require rest and also NSAIDs. Yeah.
So if you get a history of sudden sharp pain, which lasts for a few seconds to 3 minutes, we're already thinking of the precordial catch we mentioned.
Yeah.
Now, when it is left-sided and it is worse by deep inspiration, you have precordial catch. So what you just need is to reassure both the parents and if the child is old enough to reassure the child, because there's really nothing else you can do.
Yeah, so we see them in clinic and they really wonder, so what am I going to take? And you see the pain comes and goes. So the child during break, just about going out of the class, feels the pain. So are you going to place that kind of a child on NSAIDs at what interval? So we just reassure them. Now reassuring patients need to mean that we, the physicians, have enough knowledge to prove that it is not what's sinister they are thinking about. Yes. Okay, fine. So it's important. We've talked about asthma. There will be the wheeze, and so the pain, chest pain in asthma, it does not stand alone. So the wheeze, the dyspnea, probably family history, and exercise induced. And when we auscultate, right, we hear the bronchi, except it's silent chest. Yeah, so it's asthma, and then for those ones we give bronchodilators. Yeah, that's quite important. Continuing the algorithm, if in the event it is a pneumothorax, if in the event is a pneumothorax, then the pain usually, depending on the side, left or right, yeah, sharp sudden onset, and there will be real difficulty with breathing. In this condition, the child is dyspneic. Yes. It's important that we are able to identify the pneumothorax, just like a pericardial effusion will have distant heart sound. The breath sounds, you try to auscultate around that side, you get to know. And then, of course, the tracheal position. So a pneumothorax will be pushing the trachea away from the side to the opposite side. Yeah, so they'll need to have chest X-ray and exam. Now, we'll quickly jump to the cardiac causes. Let's see pericarditis. Usually, it is a sharp pain which is anterior and precordial along the precordium. Really important to know. It's exacerbated by leaning forward. There may have been a prior systemic onset. We remember it could be bacteria, it could be rheumatic. So if it's bacteria, it could mean what just occurred or what is occurring. A rheumatic, it could be reactive to something that happened. Yeah, a pharyngitis that was poorly treated. For those ones, it's important to refer to a cardiologist. Well, ST segment is elevated here and on ECG, right? So it's important that we bear that in mind. Good. And if there's a fusion, then the QRS complexes are of low voltage. Yes. For hypertrophic obstructive cardiomyopathy, which is paired with aortic stenosis because physiologically they are about the same. Yeah, for these ones, they are syncopal episode. Why do we have syncope in hypertrophic obstructive cardiomyopathy or aortic stenosis?
Because the obstruction decreases the blood flow.
Yes.
So,
yeah, so the volume of blood ejected, stroke volume,
yes,
is decreased. Yeah. So especially on exercise, during exercise where you need higher demand,
increasing demand.
The demand is higher, but the supply is less. So they just pass out. Yeah. So abnormal cardiac examination, there could be family history of heart disease in this because aortic stenosis may be congenital, and congenital things sometimes can run. Yeah, fine. Okay. So unfortunately, this our slide is microscopic, but it's important. We will be able to read it from here. So what are cardiac red flags? So apologies for our microscopic slide. We wanted to make it designed. Yeah. So if there's family history of sudden cardiac death of people less than 35 years, it's pointing towards something hereditary, right? Or young age of onset of ischemic heart disease, then there is a problem there. If there is inherited arrhythmias like the long QT syndrome of Brugada that has been well discussed before now, then it's important that we note that this is not something that we can just reassure.
Yes.
The reason for the red flags is that we do not just blindly reassure them. Now we have a hypercoagulable state or hypercholesterolemic state.
Yes. Yeah. This is important because a child that has hypercoagulable states can actually throw an emboli.
Yeah.
So they can throw an emboli either to the lungs, even to the heart, right? So that can cause pulmonary embolism or myocardial ischemia as well. So any child that has pain, right, or recent history of acquired or congenital heart disease, that is also a red flag.
Yeah.
Then when there's exertional syncope, also a red flag. When there is history of any drug abuse like cocaine in older children or amphetamines, it's important because cocaine can actually cause myocardial ischemia.
Okay, fine. So these are some of the red flags. Let's understand that this child has pain. When the child exercises, does the pain get worse? Is the child feeling like fainting pre-syncope, or does the child faint during physical health education sessions, practical in school? You are thinking of syncope that occurs with exertion. So that one you cannot just reassure, not at all. All right, fine. So summary of the management of chest pain. We've gone a long way today. Thank you for being with us. We've dealt a lot with the history. I've been able to identify the nature of the pain, the associating factor. Yeah, so if we find the pain associated with syncope or pre-syncope, we're thinking of an obstructive lesion on the left side of the heart. Yeah, so if it is constricting and general, you are thinking of maybe asthma related. Yeah, so but it's important we know in an environment where people misuse antibiotics, especially for pharyngitis, and it's either poorly treated or treated too late, that it could be pericarditis can cause it. And we're talking of the rheumatic one. So the features of the rheumatic related pericarditis we have discussed before. Yeah, okay, fine. So ECG changes, we've talked a lot about them in the preceding slide. When we think it's cardiac, and then we found abnormal examination and abnormal ECG findings, echo should be done. Because we can tell that, well, there is left ventricular hypertrophy with or without strain on ECG, but the echo is going to tell us the structural abnormality, and from Doppler, tell us the type, how severe it is. The pressure gradient across the left ventricular outflow tract will tell us, yeah. So whether it needs analgesia or whether it needs just reassurance. So a precordial cat syndrome will just require reassurance, right? But the costochondritis will require rest. and analgesia. So reassurance. Then pediatric cardiology referral becomes really, really important. Yeah, good. Okay, so let's see. Thanks, dear listeners. We want to be sure that we have been following. So we are going to give ourselves a little quiz and let's see if we are following. So please pay attention and kindly help us put the answer in the Q&A section. Let's review the performance of today. Yeah, so an 8-year-old girl presented with complaints of left-sided chest pain of 1 week duration. Now, the pain was described as sharp. It gets worse when the child lies down and relieved by sitting up and leaning forwards. Yes? Okay. So there was this history of sore throat 3 weeks prior to presentation. I was treated with amoxiclav for 5 days. Underline 5 days. 5 days. All right.
All right, so on examination, she was in painful distress and the pain was poorly localized around the precordium. So what is the most likely diagnosis?
So what do we think from the history of this child is the most likely diagnosis? Is chest pain. A chest pain. Okay, we have answers coming already. So yeah, someone has given an answer and that's really, really correct. But let's be sure that we don't have an isolated genius in the house. so let's see what could this chest pain be? Very likely. While we wait for other people to answer, we'll go back and see, reread the question. Let's just follow. So,
an 8-year-old girl who presented with complaints of left-sided chest pain of 1 week duration. The pain is sharp, worse on lying down, and relieved by sitting up and leaning forward. She had sore throat of 3 weeks duration, which was poorly treated with amoxiclav of 5 days.
Yeah.
So on examination, she was in painful distress and the pain was poorly localized around the precordium.
Yeah.
So what is the most likely diagnosis from everything we've discussed?
Okay, fine. So 2 people who have responded, they got the answer very, very correctly. Yes. So, but we will want to keep their answers quiet. Right, so we still ask the next question. Okay, fine, more answers coming in.
Yes.
Yeah, so everybody who have answered this question got it correctly. So we wait for more. Everybody who have answered the question got it correctly, right?
Yes.
So what is the most likely diagnosis? Now, the next question, what will auscultatory findings be? So let's see. So for those who have gotten it, they can just make the next set of effort. We will come back to answer all the questions. But what will auscultatory findings be? Yes, so in one of the tables, we discussed what we hear on auscultation, and we discussed something you will do to hear it better. Yeah, so let's just be sure that our audience they are paying attention. What will you hear on auscultation? While that is the answers are coming up, what will the investigation of choice be? So what will be the investigation of choice for this child? Yeah. So while it's coming up, we'll go back to bring out some. Yeah, so we have people raising up hands. We really appreciate it. But can you please put the answers in the chat box, sorry, the Q&A. So we have 4 correct answers for question number 1 already. 4 correct answers for question number 1. Now, this child had sore throat, yeah, and then amoxiclav should be for 10 days and should be started as early as possible. So this child had for just 5 days. The dose was not stated. But whatever it is, even if it was optimal dose, the duration defeats the aim. So we have answers pouring in. Yes, yes. So we are still on diagnosis. Okay, fine. Yeah. So the first person who answered has already gotten the
second question.
Yeah, the second question. I think this participant needs 50 liters of petrol because at this point, Yes, at this point, it will be very good to encourage this person. Yeah, so
Somebody answered question 3.
so the same person who got the very first answer,
Second question.
yes, has gotten the second question and has gotten the investigation of choice. Yeah, someone else, anonymous attendee, has gotten. Okay, let's start answering together. But I really want what the findings will be of the most of the investigation of choice.
Yes.
Yeah, so let's get to the end of it, then we can answer together. Yeah. Oh, okay. So somebody, yes, not the investigation of choice per se.
But
Not,
you can do it.
yeah, you can do it. It will be very good, but not the investigation of choice. Yeah, so let the answers keep coming in. So the questions goes thus: what is the most likely diagnosis? Everybody who answered question 1, they were all correct. Everybody who answered question 2, they were all correct. There was qualitative findings. Now, regarding the investigation of choice, we have different answers.
Yes.
One of it is correct, but I really want to know what findings are most suggestive from that investigation of choice that was picked up. Yeah. So, okay. So I think we should just, for the sake of time, perfect. So someone actually merits 50 liters of petrol. So maybe we'll send the virtual component of the 50 liters.
There's another answer that is also correct.
Yes, another answer is also correct. So we've had 2 answers. So thank you, Dr. Chibuike Okechukwu. Thank you, Dr. Egwavon Orosanya. In all the answers given, perfect. Yeah. Okay, someone else has answered again. Yeah.
Okay.
Yes. Thank you, Dr. Henrietta. Okay, let's rush through the answers now. Yeah. So the most likely diagnosis is a pericarditis, but the pericarditis has specific description, rheumatic. Why is it so? Let's look at the history. This left-sided chest pain is of a weak duration, but this sore throat came 2 weeks before that. So that's why it's 3 weeks at the point of presentation. Yes. Now, it was poorly treated because you'll be treated for 10 days if you are using the penicillin, but you can go for 7 days if you are using the cephalosporins. Yeah. So the pain is sharp, describing it, worse on lying down, relieved on sitting up or leaning forward. She was in distress, and most times cardiac pains are poorly localized. Yeah, unlike the musculoskeletal, that are very well localized. So we say rheumatic pericarditis, very likely. Now, auscultatory findings. So a pericardial friction rub. Yeah, a pericardial friction rub, which we said, if the child can understand and obey commands, we ask the child to hold breath for some time. So that it can be more audible. Yeah, so it's more, yes. So that would be, so investigation of choice. So we had people who said echocardiography, and we have people who said ECG. So maybe we will, since we are members of the Red Chamber, we'll put it to vote. So, but in this case, we can simply say the ECGs have it. Yeah, so it's ECG. Now, the ECG changes were clearly stated, and they were gotten by those who gave the answer. Yeah. So ST segment elevation, and then the QRS voltages are low. So perfect. So that's that. So we want to summarize.
Yes. So it's important to know every chest pain is not of cardiac origin, right? But those of chest pain origin should not be missed because they are of utmost importance.
Yeah. So any chest pain that is cardiac, something must be done about it. Yeah, so we don't end up reassuring those that have cardiac pain. Never, yes. And we do not add to the anxiety of those that are not cardiac related. Thank you. We are very much open to your questions. We are done with the presentation. Really thank you for your participation and staying on with us throughout the presentation. We are open to answer your questions, which can be put in the Q&A box. Thank you.
Thank you.
Yeah. So we can be found at number 39, Adik Tokumbo Ademola Crescent, Wuse 2. Yeah. So numbers, emails, websites, social media handles are as displayed on the screen. Yeah. We are really, really open to your questions, if any. All right, thank you for your participation. This brings us to the end of our presentation for today. You please, just to announce that the Limit Children's, okay, fine, we have a question. Okay, fine, yeah. So for everybody that registered, the slide and the CME points will be sent to the email, right? Yes. So, but we are also available on YouTube. We can easily be located. Cardio care webinars. Yeah. Thank you. Thank you. Thank you. We appreciate. Yes. So, Limit Hospital will hold our annual pediatric symposium coming up very soon. It will be a full day program where we'll touch on cases and topics in pediatric cardiology, pediatric neurology, neonatology, and a lot of hands-on experience. When the time is out and our flyers are out, we will let you know. Thank you. We'd like to bring the presentation to an end today.
Thank you.
Thank you.
The Limit Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limitchildren.org.